Hello everyone. Hereby I'm going to present a particular case report regarding adenocarcinoma, a late presenting urachal remnant tumor, rare adenocarcinoma originating from developmental defect. This research study took place in 2018 in India, and the institution where the research study was done was R.G.Kar Medical College and Hospitals. The entire research study was done on a patient who was suffering from this type of rare adenocarcinoma. The entire research study was done with all due ethical approval and keeping in mind every ethical concerns related to this research study and research work followed by this case report itself. Before entering into the actual case report, I shall explain what adenocarcinoma is in brief. So adenocarcinoma is a particular type of cancer that is found to occur in mucus-producing cells and epithelial tissues. Organs such as lung, colon, esophagus, breasts, etc. have highest cases of adenocarcinoma because these organs have a very high proportion of mucus-producing cells. So lung adenocarcinoma or non-small cell lung cancer is the highest kind of lung cancer found in United States of America. So urachal adenocarcinoma is a rare case of non-urothelial malignant carcinoma that is involving dome or midline of urinary bladder extending from urachal ligament where the tumor initially forms. So now we know the origin of the adenocarcinoma. This is extremely aggressive type of adenocarcinoma deriving from embryological remnant of the allantois and urogenital sinus. Before entering into the actual case report, a brief summarization of the entire procedure is required. So urachal remnant tumor comprising only 0.35 to 0.7% of all bladder malignancies is a rare entity. So in this particular case report, urachal adenocarcinoma treated with combined modalities, that is surgery followed by adjuvant chemotherapy, that is highly recommended by the physicians and cancer specialists. So as a rare diagnosis is rarely right, this case was even thought to be an adenocarcinoma of colonic origin with clinical and radiological resemblance with urachal remnant tumor. So this is very important for this type of adenocarcinoma should not be messed up with a colonic adenocarcinoma or adenocarcinoma of colonic origin. However, in spite of the confusing radiological features of the tumor, the diagnosis was finally clinched on the basis of immunohistochemistry, that is very important, and treated accordingly to achieve a relatively prolonged disease-free survival.
A late presenting urachal remnant tumor, rare adenocarcinoma originated from developmental defect. The case study was primarily supervised by Dr. Chaya Roy and Dr. Tushar Kantidash from R.G.Kar Medical College and Hospitals in India. So, the occurrence of this type of cancer is very rare. Only 0.01% of all adult cancer patients actually have this disease. The rare entity urachal adenocarcinoma constitutes 22 to 35% of adenocarcinomas originating from urinary bladder. Though, with the gradual descent of the bladder in the course of development, urachus should turn into median umbilical ligament. Exceptional persistence of it can give rise to urachal cyst or urachal adenocarcinoma in adulthood. With only 43% of survival rate for 5 years and mean survival between 12 and 24 months, urachal carcinoma in itself is a devastating disease. This case was particularly studied on a male patient, 52 years old, and he appeared in the outpatient department of R.G.Kar Medical College and Hospitals. The patient complained with many symptoms, on many complications, on many physical problems. The patient was hypertensive, euglycemic with past medical history of pulmonary tuberculosis in 1985. Without any significant family history, first attended the outpatient department with chief complaints of urinary urgency, that is difficulty in maturation, and urinary discharge related problems, and lower back ache for last 15 days. So, a colonoscopic report in search of origin revealed a formed extraluminal mass at lower rectum. On the basis of imaging and symptoms, provisional diagnosis of an adenocarcinoma of colonic origin or a urachal neoplasm was done, and patient was operated within 1 month of presentation. That was very fast. So without any delay, the patient was treated so that he can achieve a better disease-free survival. So procedure was grossly cytoscopy followed by cytoreductive surgery. A cystic mass approaching from the supero-anterior region was found to have adherence and involvement with the wall of the bladder. Wide excision of the urachal cystic mass was done. So, the patient was treated with adjuvant chemotherapy. Adjuvant chemotherapy was planned with cisplatin and 5-fluorouracil regimen, and patient received 6 cycles of the planned chemotherapy. The time elapsed after surgery is about 18 months till the last follow-up. Patient was asymptomatic, which established the disease-free survival to be 11 months following completion of 6th cycle of chemotherapy. That is the last day of active treatment. So this was so far we discussed about the treatment and how the doctor treated the patient actually in person.
As I have mentioned already, a thorough pathological diagnostic procedure is highly required before starting any medical treatment. So the patient went through a thorough diagnostic procedure before the physician or the cancer specialist can start his treatment. The CECT scan report showing cystic SOL involving bladder and anterior abdominal wall in axial view. With an arrow, the exact location is mentioned. The exact location of the malignant tumor is mentioned over here. A proper diagnosis is invaluable for any type of cancer, and particularly in this case, a proper diagnosis actually helped to achieve a disease-free survival for the patient. A sagittal view in a CECT scan shows SOL originated from bladder is attached to umbilical region of anterior abdominal wall. That is the exact origin and the type of the cancer. Should not be confused with any other kind of cancer. Pathological samples were obtained from the patient and they were stained with hematoxylin and eosin. After proper staining, they were observed under low power and high power microscope. So on the left side, we can see clusters of malignant cells floating in pools of mucin. Transitional epithelium of urinary bladder is also seen in adjacent areas under low power microscope. And on the right side, we can see mucin secreting adenocarcinoma is confirmed under high power microscope.
Now we shall discuss about the disease itself. So urachal cancer, first described by Hugh and Jacquin in 1863, was reported after translation and summarization by Sheldon. Begg was the first person who described the entity extensively in 1931. With mean survival between 12 and 24 months for a locally advanced or metastatic disease, and with a 5-year survival rate of only 43%, urachal carcinoma establishes itself as a devastating disease. By dint of late presentation of symptoms, early local invasion and propensity for distal metastasis, urachal cancer concludes with a poor prognosis. If and when bladder invasion takes place, irritative voiding, mucus-like discharge, and hematuria-like common urologic symptoms are presented. There are certain rules that should be followed during the treatment. So, MD Anderson Cancer Center, MDACC, has fixed the diagnostic criteria for urachal remnant tumor, including 2 main and 4 supportive criteria. The main criteria are: number 1, midline location of the tumor, and number 2, a sharp demarcation between the tumor and normal surface epithelium. There are certain supportive criteria as well. Supportive criteria are: number 1, an enteric histology; number 2, the absence of urothelial dysplasia; number 3, the absence of cystitis cystica; and number 4, the absence of a primary adenocarcinoma of another origin. So, primary and secondary adenocarcinomas are differentiated with the help of immunohistochemistry that is widely used in all pathological laboratories and pathological diagnostics. So, immunohistochemistry positivity for both CK7 and CK20 coins the diagnosis of primary adenocarcinomas of the bladder, while only CK20 is expressed in colonic adenocarcinomas. So, the choice of regimens has been based largely on case reports and single institution experiences. Tried regimens are depicted as follows. So, the urachal cancer staging system has, as defined by Sheldon in 1984, defines a stage according to its outcome, that is, what should we observe in a particular stage of cancer. That is, in stage 1, urachal cancer confined to urachal mucosa. Stage 2, urachal cancer with invasion confined to urachus itself. Stage 3A, local urachal cancer extension to bladder. Stage 3B, local urachal cancer extension to abdominal wall. Stage 3C, local urachal cancer extension to peritoneum. Stage 3D, local urachal cancer extension to viscera other than bladder. Stage 4A, metastatic urachal cancer to lymph nodes. Stage 4B, metastatic urachal cancer to distant sites, that could be anywhere. And the chemotherapy regimens that tested in urachal cancers for a long time are as follows. So I shall explain them in brief. There are around 15 regimens listed in here. First, S1, that is oral fluoropyrimidine cisplatin for 5 courses. Number 2, S1 cisplatin. Number 3, FOL FOX4, that is oxaliplatin, leucovorin, fluorouracil 600 mg, CIV over 22 hours. Number 4, irinotecan. Number 5, IFL, that is irinotecan 5-fluorouracil leucovorin once weekly for 4 to 6 weeks. Number 6, cisplatin paclitaxel ifosfamide. Number 7, 5-fluorouracil doxorubicin VP16, that is vinblastine cisplatin doxorubicin mitomycin C and cisplatin. Number 8, doxorubicin mitomycin C cisplatin uracil. Number 9, 5-fluorouracil doxorubicin mitomycin C. Number 10, methotrexate 5-fluorouracil epirubicin cisplatin. Number 11, ifosfamide 5-fluorouracil vinblastine cisplatin 16, that is VP16 cisplatin. Number 12, cisplatin 5-fluorouracil. Number 13, MVAC, that is methotrexate vinblastine adriamycin cisplatin. Number 14, Taxol methotrexate cisplatin. And finally, number 15, GMFLP, that is gemcitabine 5-fluorouracil leucovorin and cisplatin. So these are the tested regimens that are followed for urachal cancers, particularly urachal adenocarcinoma.
In accordance with the previous discussion, the stages are thoroughly mentioned in here. A report that was obtained from the patient is shown over here. The report explaining post-operative CT scan showing residual tumor as irregular thickening of bladder wall. That is mentioned with an arrow. This is the list of chemotherapy regimens tested in urachal cancers that I have mentioned already in details. So this is the list that was followed throughout the treatment. The research study was successful for both the patient and the cancer specialist as the patient achieved a disease-free survival. The case report in itself was able to draw attention of other researchers and cancer specialists who will be working in future in this area with this particular kind of adenocarcinoma. It is expected that more and more specialists, more and more researchers work in this with this type of adenocarcinoma so that improvement and further development can be done. The aim and the goal of treatment should always be a better disease-free survival along with least damage possible. So the patient receives the best kind of treatment.
So, the imaging modalities, even histopathological examination, may not be sufficient to diagnose, to distinguish between urachal adenocarcinoma and adenocarcinoma colon. So, immunohistochemistry remains as the mandatory tool to determine the diagnosis, because a particular type of carcinoma, that is adenocarcinoma colon, is itself a very devastating disease, and that should never be messed with adenocarcinoma of this kind, that is of urachal origin. So late presentation of symptoms, early local invasion, and propensity for distal metastasis make urachal remnant carcinoma a devastating disease itself, for which surgery may not be sufficient or adequate always, and should be definitely followed by adjuvant chemotherapy for a more favorable outcome, that is a prolonged disease-free survival for the patient. So this was the brief presentation for urachal adenocarcinoma. Thank you for your patience.